All right, everybody. Good morning. We have a lot of material to get through, so I'd like to go ahead and get started on time. This course utilizes audience response questions. To participate, you will need to scan the QR code located on handouts near the entrance to the meeting room or on the screen. The AUA 2024 Annual Meeting mobile app is available and free to download. When you download the app, you will be asked for a username and password. Course materials are available on the AUA 2024 website and mobile app. Use the email that you use to register. Your password is your AUA ID. You can find it on your registration badge. Good morning. Thank you to the AUA again for allowing us to present our course. This is our 8th year running. My name is Costas Lawless. I am a professor and vice chair at Jefferson in Philadelphia. I'm joined with my co-panelists today, Ed Trabulsi, who is a professor and chair from Einstein Medical Center in Philadelphia, and Mary Dunn, who is coming from Chapel Hill and is our APP representative. The AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentation all relevant financial relationships with any ACCME-defined ineligible company, formerly known as commercial interest. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the educational activity. Disclosures of relevant financial relationships are posted on the AUA's annual meeting website, auanet.org/annual meeting, and a link is posted on the mobile app. Please remember to silence your cell phones. No photos, video, or audio recordings are permitted. Courses are selected based on evaluation results, so please complete your evaluations. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration for the AUA 2025 meeting in Las Vegas. You can evaluate this session by either selecting Evaluate through the credit claim process or going to the AUA 2024 mobile app, click on the CME button, or go online and click on the CME page. Okay, with that being said, we have an audience response system pre-test, which I will go through now. Remember to scan the QR code to participate in the audience polling questions during the presentation. So if you haven't done that, please do that now. And the next slide, I will start with question number 1. I see phones up, means people are working. And we're going to go to question number 1. Okay. Which of the following is a proposed benefit of relugolix over other ADT options? Answer A, once yearly administration. B, quicker return to a eugonatal state after medication cessation. C, equivalent cardiovascular risk. D, improved cognitive function after 2 years of continuous use. And finally, E, less inflammation at the injection site. So you have 15 seconds to answer. Okay, going on to question number 2. A 72-year-old male with advanced prostate cancer is being considered for treatment with Sipuleucel-T. Which of the following disease states is approved for utilization of this medication? A, neoadjuvant in treatment-naive oligometastatic disease. B, non-metastatic BCR after definitive local therapy. C, asymptomatic metastatic castrate-resistant prostate cancer. D, bone-only symptomatic metastatic CRPC. And finally, E, diffuse metastatic CRPC post-chemotherapy. Go ahead and enter your answer. You have 15 seconds. Just so you know, you will also get these questions when you do your evaluation of the course. That will be your post-test. All right, going to question number 3. Which class of agents serves to block downregulation of T cell activity and leads to an enhanced immune response and is approved for BCG unresponsive, high-risk, non-muscle invasive bladder cancer? A, tyrosine kinase inhibitors, B, mTOR inhibitors, C, hormone modulators, D, checkpoint inhibitors, and E, aromatase inhibitors. You have 15 seconds. Polling question number 4. A 68-year-old male undergoes neoadjuvant cisplatin-based chemotherapy followed by radical cystectomy for muscle-invasive bladder cancer. On final pathology, no residual disease is noted. How does this impact his long-term outcome? A, there is no effect on his overall survival. B, his overall survival will be improved. C, he likely harbors micrometastatic disease and should be considered for adjuvant IO therapy. D, the overall survival is the same as if he were treated with a carboplatin-based neoadjuvant regimen. You have 15 seconds. All right. Question number 5. A 62-year-old female presents with metastatic clear cell renal cell carcinoma and is classified as IMDC poor risk. Which regimen is considered a preferred first-line treatment for this patient? A, ipilimumab and nivolumab, B, high-dose IL-2, C, atezolizumab monotherapy, D, temsirolimus monotherapy, and E, metastasis-directed stereotactic radiotherapy. You have 15 seconds. Okay. And I believe our last question. Which of the following agents has been approved for use in postoperative patients with locally advanced clear cell renal cell carcinoma that has been completely resected? A, IL-2, B, sorafenib, C, cabozantinib, D, pembrolizumab, or E, nothing? All right, that is the end of the pretest. And now we will get into the actual program. Our first speaker will be Mary Dunn. As I mentioned, she is an NP coming from Chapel Hill. She works with the GU Oncology program out there. Mary?
All right, good morning, everyone. Can you hear me okay? Good in the back? Okay, thank you. It's a pleasure to be with you all this morning. Thank you so much for the invitation to be on the panel. I'm going to be speaking about prostate cancer. And get to my stuff. So I tell people that I have the best job in the world because I get to work with not only a phenomenal team in Chapel Hill, but I have a multidisciplinary role where I'm half urology and half GU medical oncology. So I kind of bridge the gap between the two disciplines, and it really is a phenomenal role. We could probably spend the entire 2 hours just talking about advanced prostate cancer. So I'm going to be fast and furious through these slides so I give my partners up here time to talk about their very important disease states too. So happy to talk to anyone afterwards if you have questions, because it's a lot of information in a relatively short amount of time. So this is just how the talk is kind of set up. So we're going to define advanced prostate cancer. We're going to talk about androgen deprivation therapy, and then talk about different treatment options for the different disease states that you see listed here. So this is just kind of what we call the natural history of prostate cancer, or the clinical states model. So what we always hope when someone is diagnosed with prostate cancer is that when they're localized, that we're going to cure them and we won't have to get all the way to the end of this slide. But unfortunately, sometimes people relapse or people present with advanced disease, and we have to go through all of these different waves here. So in defining what does castrate resistance mean, that's a total serum testosterone of less than 50, and then one of the indications of other progressions. So that would be a PSA drawn on 2 consecutive times. Greater than 2 is considered PSA progression to castrate resistant, or 2 or more new lesions on imaging. And this is just kind of another way to look at that slide. So there's several different layers to what we can consider advanced prostate cancer, but today we're going to talk about distant disease and clinically recurrent disease. We could talk about biochemical recurrence and local recurrence, but for the purpose of this talk, we're going to focus on the bottom 2. So in talking about some diagnostics, we have really interesting new novel imaging, but we're going to talk old school first. So typically when patients have advanced prostate cancer, we like to get CT scans, so abdomen, pelvis. It's not a bad idea to get a baseline chest imaging, though pulmonary metastases are pretty rare. A nuclear medicine bone scan to evaluate for lesions of the axial skeleton. So they usually follow a pretty distinct pattern along the distribution of the adult red bone marrow. So we'll see skull, thorax, pelvis, spine, and the long bones, etc. So on the bone scan, we'll see osteoblastic appearance due to increased bone density in the areas of bone mets. Bone density scans or DEXA scans prior to starting folks on androgen deprivation therapy, because that can lead to osteoporosis, and having a baseline is always helpful. And then sometimes in the context of advanced prostate cancer, a prostate MRI is helpful if we're thinking about potentially doing radiation therapy to help with local symptom control. And now we have really fancy PET scans. I think there's many talks at the AUA this year about PSMA, which is very exciting. So prostate-specific membrane antigen, so targets PSMA. That's a protein expressed by prostate cancer cells. There's a couple of tracers that are used, and it depends on where you are in your institution. There are several indications for use of PET scan. So in the localized setting for patients who have very high-risk disease, patients who have biochemical recurrence after their definitive therapy, workup for progression of disease, and also before PSMA-targeted radioligand therapy, which I'll talk about later in the presentation. Sodium fluoride PETs are very rarely used, and FDG is not appropriate for patients with prostate cancer. So here's just a little more information about PSMA PET for nodal staging and bone staging. You can see the sensitivity and specificity for both are pretty darn good when we compare them with our conventional imaging. So when do we start androgen deprivation therapy? So anyone who presents with symptomatic metastatic disease, so that patient who comes into the emergency room with severe pain, obstructive urinary symptoms, anyone who is symptomatic should be started on ADT. And then patients who are asymptomatic metastatic disease. I highlighted those because there's other indications below the patients with biochemical recurrence and those types of things. But again, for the purpose of this talk, focusing on the top 2. So what is the goal of androgen deprivation? So the goal is castration, and that's that testosterone level less than 50. And there's a couple ways that we can get there. So surgically versus medically, and we'll talk about those options. So I know you all know this, but this is just an FYI slide as to why we do ADT. This is just goes through the hormone regulation of the prostate gland, and I won't read that to you in detail because you all are experts in this. So how do we do surgical ADT? Well, we don't do this a lot anymore, but I have a handful of patients, probably 5 in my practice, who have had bilateral orchiectomy. It's again, not done a lot anymore in the context that we can do this medically, but it does achieve castration levels of testosterone very quickly after surgery. It's low cost when you compare it to the cost of lifelong medical management. Obviously, compliance is not an issue. Patients don't get that testosterone flare, and of course, this is irreversible because I don't think we've yet to give anyone their testicles back after we take them out. So, have to be very mindful of that, of course. So, in speaking of medical management, so of androgen deprivation therapy, we have several different categories, and we use them in different ways depending on patient presentation and patient preference. So, we have GnRH agonists that stimulate LH and FSH from the pituitary gland to the testicles. Sometimes there can be an initial testosterone surge, so we have to be mindful of that in patients with bony metastatic disease because that can cause pain. But typically in patients with bony metastatic disease, we would use a GnRH antagonist, which we'll talk about. Castrate levels of testosterone can happen in 3 to 4 weeks. The most common agent that we use is Leuprolide, and that can be given as an IM injection or subcutaneous. It comes in various doses, and we use those depending on formularies and also patient preference and convenience. And then the GnRH antagonist, we use Degarelix, and the way that this is given is it's given as a loading dose, and then if you continue that, it's given as a monthly injection. What's common in practice, if we start with one of these, is to give the loading dose and then 4 weeks later convert people to a GnRH agonist, just because that's more convenient than coming in for a monthly injection. We do a lot of Degarelix in patients who present with metastatic disease so that we can achieve that castration level of testosterone quickly. It can happen in about 3 days, help with symptoms or patient preference, those types of things. And then kind of the newest kid on the block is relugolix. So it is an oral GnRH antagonist. So this is just a little bit of data from the HERO trial, which was a phase 3 randomized clinical trial versus Leuprolide for 48 weeks. So it sustained testosterone suppression 97% versus 89%. The mean testosterone level at day 4 was 38 for relugolix versus 625 on Leuprolide, so happened pretty quickly, those castration levels. And then what was interesting about this, hint, is that the mean testosterone level 90 days after discontinuing the medication was 288 compared to 58 on the Leuprolide arm. So the testosterone level recovered quicker than on the Leuprolide arm. And there's just a list of eligible patients, but we're using this in the advanced disease. And there's were fewer cardiovascular side effects seen in the HERO trial. So this is something to consider in your patients who have significant cardiac comorbidities, as many of our patients do, as an alternative to one of the injections. And this is not common practice to use these non-steroidal anti-androgens anymore as monotherapy, but I put it in there as a shout out to how far we've come. All right, so this just shows the different disease states in which we could potentially use androgen deprivation therapy. Again, focusing on metastatic disease, but we can use ADT in localized disease as well. But can we do it intermittently? Can we give patients a break? So as all of you know, unfortunately ADT comes along with sometimes intolerable side effects that affect quality of life. But there was a study done looking at intermittent versus continuous ADT in patients with advanced prostate cancer. So intermittent, typically if we do in clinical practice, we'll do a total of 9 months and then give people a break. But this is for very, very specific patients. So typically who have either very low volume disease and were not symptomatic upon presentation, or if they're having significant side effects from their primary ADT and just kind of want a break. But what it shows, it was along with several other studies that have been done, is there's no survival difference between intermittent therapy and continuous androgen deprivation therapy. So laundry list of side effects, right? So when we have castration levels of testosterone, any or all of these things can be significant quality of life issues for our patients. So a role of the providers, whether it's our physician colleagues or APP colleagues, is to really make sure we're doing thorough education about potential side effects and complications that can come along with this. Some are immediate and some are long-term. So we think about the long-term things like osteoporosis, that doesn't happen overnight. Metabolic syndrome doesn't happen overnight, but some of these things can happen relatively quickly, like the hot flashes and the fatigue. So we're gonna go through some of these side effects, and you'll notice a theme throughout all of them that physical activity is key. And patients look at me like I have 3 spinning heads when they come in and they say, I'm so tired from this, or my hot flashes are so bad. And my first recommendation is, well, let's move more throughout the day. So telling someone who is fatigued that they need to be doing more exercise is not always taken well in the room. I don't know if any of you have had that experience before, but that's where the data lie. Unfortunately, there's no magic pill for fatigue. I wish there was, and sometimes patients come back and they say, you know what, Mary, you were right. And sometimes they come back and say, you know what, Mary, I'm not gonna do that. And that's okay too. So just kind of going through some of the side effects. So hot flashes, the vast majority of patients who have castrate levels of testosterone are gonna have hot flashes, right? And it ranges anywhere from mild to severe. I've been doing this for over 14 years, and I've only ever had to take one patient off his primary ADT because of the severity of hot flashes. So thankfully, not a lot of patients. But the data for pharmacological management of hot flashes really is lacking in the literature. So sometimes we play around with medications that maybe we wish would help, but they usually don't, but sometimes might have a placebo effect. We love that. But paroxetine and clonidine kind of had the most data behind them, but sometimes patients just don't want to take another medication. Avoiding triggers. Some patients say that spicy foods or hot beverages are triggers for their hot flashes, so avoiding those types of things. And there's some data about acupuncture as well. It certainly won't hurt anything to try. Cognitive decline, I think, is something that we don't necessarily spend a lot of time talking to our patients about. So we talk about the things like sexual dysfunction and the fatigue and the hot flashes, but sometimes long-term ADT can cause cognitive decline. So we want to be mindful of that, especially in our older men. Again, with the physical activity and people looking at me like I'm bananas. But things like mindfulness-based stress relief. So I'm constantly recommending for folks who have smartphones different mindfulness apps to help. So things like Calm and Headspace. I don't work for Calm or Headspace, but those are just the ones that I recommend to folks. And then mental stimulation, brain training. So what I mean by that are things like crossword puzzles and Sudoku, and not on the phone. Get an actual book, because then the phone becomes distracting. And then fatigue. Something I think is really important here is talking to folks about sleep hygiene. I know you are all not surprised that everyone has really awful sleep hygiene, because we tend to not emphasize how important it is to get good sleep. So talking about things like, are you going to bed at the same time and waking up at the same time every day, comfortable room temperature, those types of things. Again, with mindfulness activities, and then treat the treatables. So it might not just be the fact that they are on androgen deprivation therapy, but they could be anemic, they might be hypothyroid, they could have vitamin B12 deficiency. So checking for other things that could be contributing to the fatigue that we might be able to treat as well. And then with the metabolic syndrome, everyone needs a good primary care provider. Thank goodness for primary care providers, and anyone who doesn't have one in my practice gets a stat referral to UNC Family Medicine, because I'm not a primary care provider and no one wants me managing their lipids. But these are things that need to be followed. So monitoring things like glucose and lipids and A1C, and physical activity and healthy diet. So we're thankful enough, as I'm sure many of you are, to have oncology registered dietitians on our staff who we can make referrals to help with these things as well. And then everyone in the room is an expert in sexual dysfunction, so I'm not going to go into all of these in detail. But one thing I do want to point out, I think sometimes we overlook the sexual health of our patients who have advanced or metastatic disease, because we might not think it's a priority for them. So I would encourage everyone to at least check in with your patients about their sexual health, and not make assumptions based on the fact that they are living with an advanced cancer or they're older, because this actually could be a priority that we're overlooking sometimes. For cardiovascular morbidity, smoking cessation, so I'm sure many of you have smoking cessation team at your institutions who are a big help. Minimizing alcohol, collaborating with cardiology for folks who have pre-existing cardiovascular conditions, and again with the physical activity. And with the physical activity, I tell people, I don't run marathons. I don't run marathons, so I don't expect people to run marathons, right? So setting up realistic expectations and goals for just getting folks moving a little bit every day and encouraging them along the way. Oh, the emotions. Has anyone ever been in a room with a patient who's had some big feelings? Yeah, and I think that this is likely multifactorial. So having that castration level of testosterone can make those moods go up and down, but also in the context of living with an advanced cancer or an incurable cancer, certainly is also a valid reason to have emotions, right? So counseling individual couples, support groups, if that feels like a good idea for your patients. I refer people to our Comprehensive Cancer Center program a lot for helping manage the mental health aspect of all of this. And there's lots of guidelines out there. The ones I find the most helpful are from the Oncology Nursing Society and the NCCN about best supportive care management. So when folks are on androgen deprivation therapy, it's really important to make sure that they are we're having conversations about their bone health. So everyone needs to be on calcium, vitamin D, and encouraging weight-bearing exercise because of the long-term potential for osteopenia and osteoporosis for these patients. Again, we talked about the DEXA scan already. And patients who have metastatic castrate-resistant prostate cancer with bone mets, we use medications to help prevent skeletal-related events. And patients who are on long-term ADT and are diagnosed with osteoporosis, we use these medications as well. They're the same medications, but depending on which indication, so whether or not it's metastatic disease for prevention of skeletal-related events versus treatment of osteoporosis is how these things are dosed. So there's two that we use most often, zoledronic acid, which is an IV bisphosphonate, and denosumab, which is a sub-Q monoclonal antibody RINC ligand inhibitor. The doses are there for you to see. The important takeaways here is that we need to be monitoring for hypocalcemia and hypophosphatemia, so ensuring that those labs are done prior to administering these medications. And also a very rare but serious side effect is osteonecrosis of the jaw. If you've seen it once, you'll never forget it. So anyone who has really poor dentition, they need to be evaluated by a dental professional prior to having this done, and patients need to let you know if they're going to have any kind of dental work outside of a regular cleaning or minor things. So anything I tell them that involves plucking or picking or cutting in the mouth, we need to know about. So I love a good timeline. I get all the feels when I get a timeline. So I tell people that I'm a dinosaur because when I first started doing this, in 2010, you can see what options I had to offer patients. There were two, right? And then things exploded, and now I get to use 2 slides to talk about the medications that we use to treat advanced prostate cancer. I actually probably missed some, but this is just a nice timeline to kind of go through how far we've come in this context. And this is just a list. I love a good list, but again, just kind of shows how far we've come and how many treatment options that we have for patients who have advanced disease. So I'm going to show you the slides with the NCCN guidelines. They used to be really easy and quick to read, and now they're not so much, right? Because we have all of these options. So I say that it's a blessing and a curse, but these are the NCCN guidelines for metastatic castrate-sensitive prostate cancer. So patients who present with metastatic disease who have never been treated before. So I like to give a shout out to single agent docetaxel, which we don't use in this context anymore, but it was such a mind-boggling study because of the results. So this was from the CHARTED trial, this many years ago at this point, for patients with castrate-sensitive prostate cancer, high-volume disease. And what it showed was that it increased survival by nearly 14 months, which is unprecedented in the oncology world. That addition of a single chemotherapy agent had this significant effect, right? So this is just a thank you to docetaxel and the people who were involved in that part of the CHARTED trial. But now we have other options. So we have oral options, so androgen receptor inhibitors. You're going to hear these names a lot in all of the different disease contexts because they're used in different parts of the spectrum of treating advanced prostate cancer. But we can use abiraterone plus prednisone. So Abi is a CYP17 inhibitor, which is an enzyme needed for androgen synthesis in the testicles, adrenals, and on the tumor itself. So it needs to be dosed with prednisone because of the potential mineralocorticoid side effects it can have because of the effect on the adrenal glands, which presents as things like lower extremity edema, hypertension, and hypokalemia. One of the most important things for monitoring patients when they're starting Abi is that they have to have their potassium and LFTs monitored every 2 weeks for the first 3 months. So just kind of an important takeaway there. Apalutamide was part of the Titan study and showed a 33% reduction in the risk of death. There's a lot of information on these slides that unfortunately I don't have time to go through all of it, but you have access to them. It shows you the different mechanisms of action and the trial data. Enzalutamide is another AR inhibitor. Was in 2 studies, so ARCHES and ENZAMET, that both showed really good numbers in this patient population. And then what we're seeing a lot now, and what it's very patient dependent, depending on exactly what their disease status is. So if they're high volume versus low volume, what their comorbidities are. But we're putting a lot of people on so-called triplet therapy now. So their primary androgen deprivation, which we always keep people on their ADT. That doesn't go away. That kind of serves as the base, and we just add stuff to it. But the PEACE trial was ADT plus docetaxel plus abiraterone. So we're doing a lot of that now based on the data from the PEACE trial. And the way that this is done is the docetaxel is given over 6 cycles. The abiraterone is dosed daily, and then, of course, their primary ADT. Once the chemotherapy is complete, the primary ADT and the abiraterone stay. So they do chemo, all 3, and then once the chemo is done, they continue on the Abi and their ADT. And then another so-called triplet therapy, so ADT plus docetaxel plus darolutamide. So some take-homes here. So the chemo regimen is the same, so 6 cycles, that's dosed every 21 days. Once that's over, the darolutamide and the ADT continue. A little take-home with the daro is that it can be a little bit more difficult dosing for patients. So it's 600 milligrams BID, so that's 2 capsules twice a day. And if your patients have a hard time remembering to take their medications, this might not be the best option for them. And then I love a good chart. So this is just an FYI chart comparing everything for your reference. So what happens when patients are castrate-resistant? When we get to this point, what does that mean? So I don't know how many of you see patients who have non-metastatic castrate-resistant prostate cancer. So essentially, these are patients who have a rising PSA, a castrate testosterone, but their imaging is negative. So we think about patients who may have had a biochemical recurrence after their localized prostate cancer. They were put on ADT and their PSAs are going up, their testosterone is low. We re-image them and there's nothing there. So how do we treat these patients? I'm old enough to remember when we used to treat them with ketoconazole and hydrocortisone, and that's bananas, right? But I did have a patient who responded to that for like 11 years, which is also a little bit bananas. But now we have options. You're going to see some of the same drugs used in this context, right? So enzalutamide, and I'll talk about some of the side effects with these. So with Enza, sometimes we see these myalgias, a little bit more fatigue in folks who take Enza, so being mindful of elderly patients. And there is a seizure warning on this medication, so anyone who has a seizure disorder, we should avoid prescribing Enza. Apalutamide, our old friend again. See, we're just like friends with all of these drugs now. But side effects with this, we can see arthralgias again. And a unique side effect with APA is that it can cause hypothyroidism. It's not something we're used to monitoring in prostate cancer. We do in things like advanced kidney cancer, but it's a little bit different in prostate cancer. So making sure that they're getting a TSH checked when they come in for their labs. And then our old friend darolutamide can be used in this context as well. So the decision-making process on which one of these medications do I pick really is shared decision-making. So it is what are your patient's comorbidities? What are their preferences? What is their insurance going to pay for? What are their drug-drug interactions? Hopefully in the future we will have more data to support sequencing of these medications and things like that. And then there's your FYI chart. Okay, this gives me heartburn. So this used to be very, very easy to follow, and now it's like, good Lord, I need my glasses fixed and like 5 hours to go through what this chart says. But these are the NCCN guidelines for metastatic castrate-resistant prostate cancer. So patients who have metastatic disease, who are being treated, whose PSA numbers are rising, who have 2 or more new lesions on their imaging. And the treatment for these patients is highly dependent on what they have had before. So you can see these 4 boxes here. If they did this, then consider this. So it's a little more tricky to think about than it used to be back in the day. What do we have to take into consideration? Everything, constantly, all the time, right? So this is not, this is more complex than it seems. So what's their prior treatment? Are they having any treatment-related lingering toxicities, right? So is anyone still having peripheral neuropathy if they got chemotherapy? What are their comorbidities? What do the patients want? What are their goals of care? Do they want to be as aggressive as possible, or do they want to be minimalistic, right? So talking to patients about goals of care is always something we need to be doing in patients who have advanced disease. What are their barriers to care? So do they live 3 hours away? Can they come in and have their lab checks for ABI every two weeks? Do they have any way to get here, transportation? And what are the drug-drug interactions? So we have a clinical pharmacist on our team, thank goodness for our clinical pharmacist. I don't know if there's any pharmacists in the rooms, but you all are such important members of our team. So these are the options for folks with metastatic castrate-resistant prostate cancer. So docetaxel does have a place here, and that's what we've been using the most. Cabazitaxel, so a little take home with cabazitaxel is that it can cause myelosuppression, specifically neutropenia. So this is given with growth factor. You need to be very mindful of giving this for our patients who are elderly, and sometimes we start people on a dose reduction. And then other chemotherapy-related side effects that you all are probably familiar with. None of our chemos require central access, so people can get peripheral IVs. They don't have to have central access. And then essentially most of the anti-androgens that we've already discussed were first FDA approved in this context for metastatic castration-resistant prostate cancer. So the ABIs and the ENZAs have been around for a long time, but we just kind of figured out based on data from clinical trials that we can use them in different contexts. Our old friend enzalutamide. So a little blurb about cross-resistance. We don't quite know why some people have cross-resistance between ABI and ENZA, because they have a distinct mechanism of action, but this is something we have to consider. There is no biomarker. There's no way for us to figure this out, but in clinical practice, what we try and do is trick the cancer into thinking it's not seen them before. So if you're doing ABI, then maybe break it up with chemotherapy and then maybe go to ENZA. But we're not quite smart enough to figure out why. There is an immunotherapy, so Sipuleucel T. This is mostly used in patients with asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer. It's an autologous cellular immunotherapy, so patients have to go to pheresis and then come back and to our infusion center to have their treatments. It's hard to monitor PSA on Sipuleucel T because it doesn't affect the androgen pathway, so doing some patient education up front, because we rely so heavily on that PSA biomarker as a response to treatment. So educating patients that we may not see a PSA response because it takes a long time to develop an immune response, but that doesn't mean that it hasn't worked or is not helping. And then a couple of radiopharmaceuticals. So radium-223 is an alpha particle emitting radioactive agent. We use this in patients who have bony metastatic disease. Not appropriate for patients who have visceral metastatic disease because it has no effect on the visceral metastatic disease. This is given every 4 weeks for 6 doses. Myelosuppression is also a potential side effect here, so making sure we're checking CBCs before. And then our newest friend, lutetium, was approved a couple of years ago after showing a benefit over best supportive care alone. So I mentioned earlier in the talk about using PSMA PET for metastatic patients. So In order to be eligible for this, patients have had to have at least one androgen receptor inhibitor and 1 or 2 prior chemotherapies, and they must have a PSMA positive PET. So that's defined as at least one tumor with uptake greater than the normal liver. So it's important that when you are ordering these for patients that you put in the order to evaluate for treatment with lutetium, so that your radiologists know that that's what we're using this for. Some unique side effects: dry mouth. So I use ice chips before administration to help with that, and nausea. So folks get antiemetics beforehand. We can also see anemia. So I do have folks get their CBCs checked in between visits and coordinate that locally if they live far away. So just a couple slides about the genetics of metastatic prostate cancer. So this trial here showed that sequencing of germline DNA from nearly 700 patients demonstrated that roughly 12% had a mutation in a DNA repair gene, the most common one being BRCA2. The take home here is that we need to be doing germline testing on all of our patients who have metastatic prostate cancer, or at least offering it to them, have them meet with a genetic counselor, because sometimes people have fear about doing that. Most patients, as you see, won't have a germline mutation, but in those who do, we can offer them different treatments down the road, and I'll have a slide on that. And that's just another slide about germline mutations. So these are patients with special circumstances. So there's germline mutations. These are the patients in which we use PARP inhibitors. They're oral agents. These are the trials showing benefits with these medications. We typically don't use them up front because we typically don't have the germline testing back up front. But something to have in our back pocket for patients who have germline mutations. And then if they have germline mutations, having their family members also consider having at least genetic counseling. All kinds of practical considerations. So adherence to oral medications, evaluating barriers to care. This is where, bring in your teammates, right? So your nurse navigators, your social workers, all the people who can help with the complex management of patients who are living with advanced prostate cancer. And keep learning. This is an ever-evolving landscape. I can guarantee you that this talk will be different next year. And then future directions, all the things that we always talk about, right? So how do we sequence things? Other new agents and combination therapies. I'm willing to bet we'll be seeing different combination therapies in the future with metastatic prostate cancer. This is just a slide to show that we do use these medications in non-metastatic prostate cancer. So for folks who treat that, so our urology colleagues and radiation colleagues, just so you're aware, we do use systemic treatment for those patients as well. So unfortunately, we still don't have a cure for metastatic prostate cancer, and shared decision-making is really important between providers, patients, and their caregivers. Encouraging folks to enroll in clinical trials, either at your institution or other places. Always incorporating best supportive care is key. Talking about and documenting advanced care planning is also really important for our patients with incurable cancers. Don't forget about the caregivers. They carry a heavy burden as well. This is really complicated stuff. And one thing I always let my patients know, that just because there are so many treatment options now does not mean that they have to exhaust them all. Hospice is always an appropriate choice for patients who have advanced disease, who are not interested in continuing down the line of treatment. Thank you.
Thank you so much, Mary. We're going to hold questions until the end.
Morning, everyone. I'm Ed Trabulsi, Jefferson Einstein in Philly. I'm going to talk about bladder cancer, and it's become quite a explosive field lately. There's a lot of changes, a lot of growth, a lot of new options, which are great. I'd like to give a shout out to BCAN. Those of you who have not seen the BCAN website, it's an amazing organization, the Bladder Cancer Advocacy Network. They also have probably the best patient information pamphlet I've seen for bladder cancer, spanning the whole spectrum of disease. It's downloadable, you can order it. So I use that with every one of my bladder cancer patients. So we're going to talk about bladder cancer in terms of the diagnostics and the incidence, and then specifically the different disease states and how we treat them. I don't need to tell this audience what a burden bladder cancer is. It's the fourth most common malignancy amongst men in the US. It's also a very expensive cancer. There's a lot more patients living with it, with a 10 times higher prevalence than incidence, because most of the patients have superficial, less threatening disease, so it's a disease they commonly live with. It's a disease of older patients in general, around 68. And cystectomy still has a very important role, even though everything we're doing in the superficial space is to try to delay or avoid a cystectomy. The definitions are really important, and we use a lot of jargon or acronyms, but we really sort of separate bladder cancer into the low-risk, non-muscle invasive bladder cancer patients, the high-risk, non-muscle invasive, and then muscle invasive or metastatic. So talking about the old term superficial bladder cancer or the non-muscle invasive bladder cancer, the AUA has a really simple table, risk stratification, and we divide patients into low, intermediate, and high risk. And interestingly, intermediate risk is kind of the catch-all, everything that's not low risk. Low risk is a single small little low-grade tumor. High risk are the ones that we really worry about. And then in the middle, these are patients that recur, even if they're low risk, or if they have a larger tumor that's still low risk, and the very rare low-grade but superficially invasive tumor, low-grade T1. And this space actually is now being investigated in clinical trials for new intravesical agents, specifically for the intermediate risk, to try to sort of appropriately risk stratify these patients and offer the appropriate treatments. And the sort of algorithm looks like the New York City subway map. It's pretty complicated, but basically, if we figure out which of the three risk categories the patients fall into, it's fairly straightforward to know what to offer them. Intravesical therapy has been the mainstay of treatment for superficial or non-muscle invasive disease. Typically it's given in the office, and this is where APPs are vitally important. BCG has been the mainstay, really the first and most commonly used immunoagent in cancer. And then we have newer agents, nadofaragene, and just in the past 2 weeks, another product that I can't pronounce, the Altor N803 product, was just approved as well. And then intravesical chemo has become much more commonly used, partly because of its efficacy and partly because of the common supply disruptions of BCG. But BCG remains the gold standard. This is the mycobacterium similar to tuberculosis. It's a non-specific immune adjuvant, and it definitely is the gold standard which all treatments are compared because it reliably reduces recurrences and, more importantly, reduces progression, so superficial disease becoming invasive disease. It is a live bacteria, so there are risks, usually mild sort of flu-like symptoms, but very rarely you can get systemic BCG infection. And there's also been a real awareness that because of its immune nature, that constant stimulation of the immune system with maintenance therapy really does improve efficacy. So this is another complicated slide. There's a lot of different thoughts on different pathways on how BCG works, using innate immunity and adaptive immunity, and probably all of this comes into play. This is important because the newer agents that are also immune-based, like nadofaragene, like N803, look to focus on certain parts of this mechanism to improve response rates. BCG is typically given once a week for 6 weeks. We tell the patients to hold it for 2 hours if they can, and then the maintenance schedule usually once a week for 3 weeks. We'll talk about reduced dosing. That's used to be held for patients who didn't tolerate it as well, but we switched to reduced dosing whenever we have BCG shortages. And there was a trial from Europe looking at the role of reduced dose BCG, and actually it looks like the results are fairly comparable. So 1/3 strength BCG compared to full strength BCG for both intermediate and high-risk non-muscle invasive bladder patients. It did not seem to be significant detriment to treatment efficacy. The AUA shortage, the BCG shortage was addressed by AUA in a statement, and basically, as you would expect, it's sort of recommending that we save BCG for the patients that need it the most. And so if we look at number one, we shouldn't use it in the low-risk patients. For the intermediate-risk patients, we might use monotherapy. The high-risk patients should really get full dose if they can and maintenance if available. When we talk about recurrences, this is another aspect where the definitions can get very confusing. This is drawn from a FDA guidance document. Urology met with FDA to try to figure out a framework for registration and approval of new treatments. And the FDA wanted to very clearly define who we were treating and what they would consider adequate prior treatment in the second line. And so from this document came the concept of adequate BCG. So you can't really call a patient a BCG failure if they really haven't gotten enough BCG. And so adequate BCG is patients that have gotten 2 induction courses of BCG, 6 weeks each, and got at least 5 out of 6 of the prescribed treatments, or an induction course in maintenance, and so 5 out of 6 induction, 2 out of 3 maintenance. So if they've had that and then have a recurrence, that's when we start talking about BCG failure. And there's 4 terms that sort of encompass our old term that we used to say BCG refractory, and now we're trying to parse it out very more accurately. We still use the term BCG refractory. That's refers specifically to patients that are never disease-free after an intravesical therapy in the first 6 months. So they get treatment and they never have a clean bladder. BCG relapsing are those patients that get BCG, do achieve a complete response, and then have a later recurrence of tumor. We have BCG intolerant, and those are patients that don't tolerate BCG. And then BCG unresponsive, which is sort of the new mantra in patients that we're saying are failing BCG, is a combination of BCG refractory and the relapsing patients who relapse within the first 12 months if it's CIS, or within 6 months if they have papillary disease. Salvage therapies have been put forth. There's been a lot of things that have been tried in the past for BCG failures. You can see here intravesical chemotherapy with gemcitabine and docetaxel, old therapies that we don't use very much anymore like valrubicin. It sort of indicates the burden of disease and an unmet need because patients really don't want to have their bladders removed. The benefit of postoperative chemotherapy has also come to the front. The SWOG did a randomized trial of intravesical gemcitabine in the post-op area after a bladder biopsy versus a saline sham infusion, showing a significant improvement in tumor recurrence. So this is now the standard of care. So patients that have visible disease that either have a history of bladder cancer, so you're confident that it's going to be another bladder cancer recurrence, or cystoscopically, morphologically, you're very convinced it's a tumor, giving intravesical gemcitabine post-op significantly reduced the recurrence rate over 4 years. The role of immune therapy systemically, and specifically the immune checkpoint inhibitors, has been defined in the high-risk non-muscle invasive space as well. This is primarily pembrolizumab, which is an anti-PD-1 treatment. This was approved in January 2020, specifically for BCG unresponsive patients with CIS with or without papillary disease. And this was from the KEYNOTE-057 trial that showed a complete response rate of 41 patients and a median duration of response of greater than a year. Nadofaragene or Astilogen, this is another intravesical immune treatment. This is a replication-deficient recombinant adenovirus, and basically it delivers interferon alpha into the bladder epithelium. Again, it's the same approval criteria, CIS with or without papillary disease in the BCG unresponsive space. Also approved for the non-CIS papillary disease as well. This is a single dose and can be repeated at 3, 6, and 9 months. This was approved about a year and a half ago. When we look at the Lancet Oncology paper on the registration trial, you can see, looking at the efficacy analysis, that at 12 months, the complete response rate was 24%, so not eye-popping, but still better than historical controls. And in the papillary non-CAS, higher, as you'd expect. Shifting gears to muscle-invasive bladder cancer, so disease that's invasive, penetrated through the muscle, into the muscle, or through the muscle. These are what are potentially lethal bladder cancer patients. So this is clinical stage T2, T3, or higher. And these patients typically, if they're non-metastatic, we would think about a radical cystectomy for the medically fit patients, or combined trimodal therapy with chemoradiation who refuse cystectomy or are not good surgical candidates. Looking at the results of cystectomy for muscle-invasive disease, not as optimistic as we'd like. If you look at large retrospective single institution studies, even with radical cystectomy, the disease recurrence and mortality of bladder cancer at 5 years is 30–40% or higher. So the SWOG group, led by H. Bart Grossman, looked at strategies to try to improve survival after radical cystectomy for muscle-invasive disease, and specifically at giving neoadjuvant or pre-surgical chemotherapy. So this was a randomized trial of patients that are scheduled for cystectomy that were randomized to 3 cycles of standard MVAC followed by surgery versus upfront surgery alone. And you can see here a significant improvement in overall survival, improved from 45 months to 77 months in the patients that got preoperative chemo. So it's a little bit of a frame shift in our typical approach, because we have an anxiety to get these patients to the OR quickly, to get the bladder out as quick as possible. So slowing down, giving chemo, and then taking the bladder out. But the data is the data, and this has been upheld in several other similar type trials. The other important thing is that the patients that achieved a good response pathologically, if their final pathology showed no residual disease, those patients had the best overall survival. And as I said, there's been several other neoadjuvant studies, all cisplatin combination chemo-based, looking at preoperative chemo, all showing improvement in overall survival, and also showing better outcomes when they achieved a complete response pathologically. A newer regimen using the same 4 drugs, accelerated or dose-dense MVAC, is sort of the new standard of care, one of the standards that we use. So old-fashioned MVAC was very toxic, and so giving accelerated doses with growth factor support shortens the time of the chemo regimen. It's typically given every 2 weeks, less of a delay for surgery, and is tolerated very well. We were involved with a trial with Fox Chase looking at a neoadjuvant dose-dense MVAC, and this is a typical sort of trial design where they would get upfront diagnostics, and then they get 3 cycles of the 4 chemo drugs with growth factor support, and then restage them and try to get them to the OR within about 4 to 8 weeks after the end of chemotherapy. And in this trial, almost exactly mimicking the SWOG original MVAC trial, we had a pathologic complete response rate of 38% in our trial. And more than 50% of the patients had downstaging, so from T2 or T3 to T1, TIS, or T0. The sort of the controversy on when to give chemo is nuanced. A lot of patients say, why don't we just take it out, see what the pathology is, and then give me chemo afterwards? Why do we have to delay things? And this is something that's not in our arena necessarily, but this is a slide from Jeannie Hoffman-Sensitz, who's a noted urothelial carcinoma expert, medical oncologist at Hopkins, used to be at Jefferson. And so she sees these patients, and neoadjuvant patients followed by surgery, that disease course, treatment course, is much better tolerated than upfront surgery and then trying to give chemo afterwards. But this question has been investigated, and looking at adjuvant versus neoadjuvant chemo, the advantage is that we're potentially not over-treating patients. There are some patients cured by cystectomy alone. There are patients who won't respond to chemotherapy, and we're delaying their potentially curative surgery. On the flip side, a significant proportion of otherwise healthy patients who undergo cystectomy for a variety of reasons may not be able to tolerate chemo post-operatively. There's a European trial trying to look at the timing of chemotherapy, and this was looking at specifically adjuvant chemotherapy versus delayed chemotherapy given at progression. This was closed because of poor accrual, but this also highlighted that neoadjuvant controversy aside, if we do a cystectomy and get a bad pathology, a bad surprise, that upfront earlier systemic therapy definitely can improve overall outcomes rather than waiting for radiographic evidence of progression. The overall survival was significantly improved in the patients that got early adjuvant therapy. There's a combined guideline between ASCO and the European Association of Urology. I picked out two of the more pertinent, powerful aspects of the guideline. So neoadjuvant chemotherapy is recommended for muscle-invasive bladder cancer patients, should be cisplatin combination-based therapy. And patients that are fit and have metastatic disease, cisplatin chemotherapy, either with gemcitabine cisplatin, MVAC, or dose-tense MVAC, should be considered. Now, this may change with the recent data, which I'll speak about later, of enfortumab with pembrolizumab. So not to be repetitive, but multiple studies shown that in patients that go to surgery that got neoadjuvant chemotherapy that have pathologic downstaging, those patients tend to do the best. Now, even that being said, we still have a significant recurrence rate, and there is definitely still unmet need in this potentially lethal cancer. Looking at neoadjuvant checkpoint inhibition before radical cystectomy, this has been looked at in the PURE-01 trial. This is patients who could not get chemotherapy, and they got preoperative pembrolizumab. So this was 3 cycles, 3 weeks apart, when you look at the pathologic complete response rate, it's eerily similar to the chemo data. So in this trial, 39% had a pathologic complete response. So this question has not fully been answered. And so in patients who can't tolerate cisplatin combination chemotherapy, there certainly may be a role for another systemic neoadjuvant strategy for them prior to surgery as well. Adjuvant therapy after surgery, patients that have residual disease are at higher risk for recurrence and death. And this was in the guidelines, the NCCN guidelines, looking at adjuvant therapy. They stratify by whether or not the patients got neoadjuvant chemotherapy. The patients that got neoadjuvant chemotherapy and still have T2 or worse disease definitely are the highest risk for recurrence. Those patients, you'd think about adjuvant immune checkpoint inhibition with nivolumab. In the patients who have upfront cystectomy and have just T2 disease or less, they're at lower risk. They have been challenged with any systemic therapy. And so typically we would give adjuvant therapy in the non-chemo treated patients who had more locally advanced disease, T3, T4, and node positive. When we move into the metastatic space, this is where we've had a revolution of treatments, specifically looking at immunotherapy and PD-L1 inhibition. And I certainly do not pretend to understand the mechanisms, but my simplistic way of thinking about this is that we have the gas, we have the brake. And so the immune system has suppressor cells, activator cells, and what we're trying to do is step off the brake and rev up the gas. And that's what the immune checkpoint inhibitors do. And so there's several different targets that are investigated, that are druggable, and all of this is under active investigation, either agonist antibodies for stimulatory or antagonist blocking antibodies to suppress. If we look in the NCCN guidelines for systemic therapy in locally advanced or metastatic disease, we can see here that combination chemotherapy, either gemcitabine cisplatin or MVAC, are definitely recommended. And the newer sort of regimen is the pembrolizumab with enfortumab, which I'll talk about. In the patients that are not cisplatin eligible, those patients really probably should be steered towards pembrolizumab with enfortumab because the carboplatin regimens really seem to be detrimental in terms of response rates. Another definition that's not always intuitively obvious: what makes a patient cisplatin ineligible or unfit to get cisplatin? It's kind of a cruel twist of fate that one of the most active agents in urothelial carcinoma depends so much on renal function. But performance status is a vital component of this. It is a toxic regimen. If the patients are not getting out of bed, they're probably not good candidates. Creatinine clearance is probably the most common serologic finding that would disqualify a patient. Typically, they say a clearance of 60 cc's per minute. A lot of places will push it down to 50 cc's per minute, even with split dosing. I knocked over the mouse here. And then maybe not so obvious in the urology audience are things like hearing loss, peripheral neuropathy pre-existing, because these are such common side effects of cisplatin, or heart failure. So this is already kind of old, but this sort of demonstrates what a barren wasteland we had in bladder cancer from the 70s to the 2000s. We had cisplatin approved in 1978, and then gemcitabine approved in 2008, with really nothing in between. And then in the last 10 to 15 years, it's been an amazing explosion of different treatment options in this space, which is really heartening. There's still definitely areas of unmet need. We're not curing everyone, and it really still will probably be stratified between cisplatin eligible and cisplatin ineligible in terms of what we're going to offer. But this is kind of a complicated algorithm, but we're fortunately in the bottom left, we're getting more and more treatments in this space that we can offer patients. Again, stratified between eligible for cisplatin or not. Maintenance therapy has also been looked at, so if they have a good response to chemo, it's not a regimen that they can get continuously, so what else do we offer them? Avelumab is another immune checkpoint inhibitor, and the Javelin study looked at patients that had a good response. These are locally advanced or metastatic urothelial patients, a good response to upfront chemo, and then were randomized to avelumab versus best supportive care with a primary endpoint of overall survival, and this did show an overall survival benefit, so this is in the guidelines. Patients with metastatic disease that get a good response to chemo should then go on to get avelumab. Checkmate 901, this also looked at advanced urothelial carcinoma in the first line. This randomized gemcitabine cisplatin and then nivolumab, followed by nivolumab monotherapy maintenance versus cisplatin and gemcitabine alone. This was powered for overall survival and showed significant improvements. So combination therapy of cisplatin-based chemo with immune checkpoint inhibition and then follow-on adjuvant PD-L1 treatment does show benefit as well. And then just, about 8 weeks ago, enfortumab with pembrolizumab was approved for first-line therapy. This is the EV-302 trial. So enfortumab is an antibody-drug conjugate. The antibody targets Nectin-4, and it has a toxic payload. Nectin-4 is overexpressed in a variety of solid tumors, so we definitely will see this in other organ sites, but obviously it's overexpressed in a majority of urothelial carcinoma patients. This was a head-to-head comparison, first time this has been done, looking at the EV combo with pembro versus cisplatin-based chemotherapy. This one was gemcitabine with cisplatin, did allow carbo, one-to-one randomization, and this was powered for superiority and did show significant improvements over chemotherapy. This is paradigm changing. Dramatic improvement in overall survival and progression-free survival in these patients. Hazard ratio of 0.45, meaning a 55% improvement. So this may really change how our medical oncologists approach these patients. Our sort of gold standard has always been cisplatin, if you can get it in them, and then we don't really have much else to offer them. Second line, we're definitely going to start seeing real challenging discussions on which treatment to start with first, but this is a good thing, another option to offer patients. For the second line and beyond, so this is for patients that have failed chemotherapy and immune checkpoint inhibition, there are other options, and this is another space where we didn't have anything, just a couple years ago. Erdafitinib is an oral FGFR inhibitor. This is improved for second-line metastatic urothelial carcinoma. This is biomarker-driven, so we have to have alterations in the FGFR2 and 3 receptors. And in a heavily pretreated patient population, overall response rate of 32%, which is, in this patient population, a good thing. These FGFR alterations are approved in a minority of patients, so it's not certainly a panacea, but if they have the proven alteration, it's definitely a viable treatment option. Enfortumab used to be for second line and longer, so this is going to move up. And then there's another antibody-drug conjugate, sacituzumab govitecan. This is a antibody directed to trophoblast cell surface antigen 2, or TROP2, and this also is upregulated in most urothelial carcinoma patients. Again, in a heavily pretreated group of patients, overall response rate of 27%. So the NCCN guidelines, kind of like Mary showed with prostate cancer, keep getting more and more complicated, but you can see now all of the different agents, and even in patients that fail all of the things I've talked about, there is still a role in the good performance status patients for single agent chemotherapy or combination therapies, even without level 1 evidence. So we look at second line therapies, we definitely check the FGFR status, and then sort of look at where these patients could fit in. And again, this is a little bit repetitive. A more sobering aspect of all of this is we have all these agents, but we're not necessarily getting them out to the patients. So if we look at the pool of patients that have newly diagnosed locally advanced or metastatic bladder cancer, only about half of them in this study from a couple years ago even got first-line therapy, and only 17% got second line. So even though we've had these advancements, getting it out to our patients remains a challenge. And then this is a schematic of all of the other potential cell surface and immune modulatory targets that are looked at and in development and investigation. So there definitely is more on the horizon, either stimulatory or suppressive. Combinations definitely are also on the horizon, so looking at immune checkpoint inhibition with other agents, not surprising. We all know that in most solid tumors, a single bullet is usually not enough. And then just a little bit about upper tract urothelial carcinoma. This is an uncommon, considered a rare disease type. We think about it very similarly to bladder cancer because it is urothelial carcinoma, but it's not always exactly obvious that we can extrapolate everything we have from bladder to the upper tract. Jeannie Hoffman-Sensitz, again, one of our former partners who's now at Hopkins, led an ECOG-ACRIN trial, very similar to the neoadjuvant cystectomy trial, looking at neoadjuvant dose-dense MVAC. I truly think that in the upper tract urothelial space, neoadjuvant therapy makes more sense. Those patients are destined to have a nephroureterectomy. We know that their renal function is going to be compromised directly by our treatment, and so trying to treat them earlier does make more sense. Didn't have as high a pathologic complete response rate, but we do need to remember that a TURBT alone in bladder cancer does have a significant incidence of P0 if you took the bladder out, whereas an upper tract tumor where we're using ureteroscopic biopsies and lasers, we don't have the ability to debulk those tumors nearly as well. Another important trial that keeps being reported out as it matures is the POUT trial. This is looking at adjuvant chemotherapy, even in upper tract after nephroureterectomy. And so there is still a role in the patients that have high risk or adverse pathology after their kidneys removed who can tolerate chemotherapy to try to give it to them post-op. And with that, I thank you.
All right. So we're going to round it out. Talk about renal cell carcinoma. Again, for those in the audience, I don't really need to dive into this too much, but renal cell carcinoma, about 2 to 3% of all cancer deaths in the US. It has increased as of yet. There are some predictive or some factors that may lead to renal cell, such as smoking and obesity. Also, there are some hereditary disease states that will actually lead to renal cell carcinoma as well. Surgical resection does remain the only effective therapy for clinically localized renal cell carcinoma. So for the 2023 kidney cancer statistics, they did combine renal cell carcinoma with upper tract urothelial or renal pelvis tumors, although just given the numbers, because upper tract urothelial is so uncommon, really renal cell really drives these numbers. So for new cases, in the top 10 malignancies present in both genders. However, when you look at mortality, they fall out of both genders. So certainly the cancers are seen, however, they're just not as lethal as some of the other cancers. And I will note that both prostate and bladder are present in those as well. So when do these cancers actually occur? Sometime toward the end, the 6th and 7th decades. Although that being said, again, because of the mortality, these patients are living with these diseases for a long time. Looking at the histologic classification of renal cell carcinoma, really I think a way to really look at it from a practical standpoint is it's binary. There's clear cell and there's non-clear cell. The non-clear cell is split into papillary. Now we combine type 1 and type 2 into a single papillary nomenclature, chromophobe, and then the others, both benign and malignant as you go down the list. But again, I think the key of this is that more than 90% of all metastatic renal cell are actually of the clear cell histologic variant. This is what they look like under the microscope. Clear cell, again, that clear cytoplasm. very distinctive, papillary, have those papillary fronds, both type 1 and type 2, with type 2 being a little bit more eosinophilic, but again, most pathologists are combining these at this point. Chromophobe and oncocytoma, although in this slide they look very distinct, however, under the microscope they can be very, very similar and can be a diagnostic difficulty, especially in patients who have a core biopsy, and these oncocytic neoplasms are the ones that can be a problem. Associated mutations, I've listed down here the ones that I see the most in my practice, obviously von Hippel-Lindau, and also I see a fair amount of patients with the Birdhog-Dubé genetic predisposition. As far as staging goes, most of the patients who present with renal cell carcinoma have a localized disease with less with regional and distant and metastatic disease. And looking at survival, as you would expect, again, the patients with localized disease, so T2 and below, those are the ones who actually have a very high survival with treatment. And then as you go out to regional involvement, like nodal involvement and distant metastases, you see the survival actually begin to fall off. And I would like to point out that approximately, again, almost a third of patients who present with renal cell carcinoma is metastatic at presentation. Although this is the conventional teaching, I do think that number has actually fallen off over time. One of the features of renal cell carcinoma that makes it so difficult to treat is its resistance to chemotherapy. There were 83 trials, over 4,000 patients, with the response rate being about just 6%. There's really limited data. There is some response to chemotherapy in patients with non-clear cell renal cell carcinoma, and these are the agents that have some efficacy to those actual non-clear cell patients. However, certainly we've done something right going back into the 70s and looking at by year as far as survival goes in patients who present with metastatic renal cell carcinoma and renal cell carcinoma overall. The survival, it's hard to tell by this, but it goes up for both the 5-year survival and the 1-year survival over time. So certainly our therapies have shown improvement. As we all know, renal cell carcinoma is an immunologic, or it's an immune responsive type of cancer. This has been proven by various observations about the tumor. There are spontaneous remissions that have been documented. There is a known abscopal effect in renal cell carcinoma where you will see regression of metastases after there has been treatment of the primary tumor. There is an increased risk of cancer in immunodeficient states and patients who are who have received renal transplants who are rendered immunodeficient by the medications there are. And these tumors do possess significant tumor infiltrating lymphocytes, which is the reason why they are responsive to some of the checkpoint inhibitors, which we will talk about later. Kevin Zarabi is one of our medical oncologists at Jefferson, a young guy, very, very sharp. I've had conversations with him about renal cell carcinoma. He treats a lot of our metastatic renal cell carcinoma. And I talked to him about, I said, Kevin, how do you really look at patients with renal cell carcinoma? Well, how do you evaluate them? And so this is his way of evaluating them. I think it makes a lot of sense. It's a little bit simplistic, but actually is very good for us as urologists. The first thing he does is risk classification. He almost exclusively uses the IMDC risk model. These are the factors that figure into it. And as you can see, survival for patients who are IMDC favorable versus unfavorable makes a significant difference, and this is why we use these models. This is another way of looking at IMDC criteria for patients with metastatic renal cell carcinoma. And it's hard to read, but the feature that I would like to point out, just by the categories that figure into the IMDC classification, for patients who present with metastatic renal cell carcinoma, the vast majority of them are classified as IMDC intermediate or poor risk, about 75 to 80% of them, with just a minority being favorable risk. So that's classification. So the second step that Kevin asks is, what do we do with the primary tumor? Should we remove it or should we not remove it? Back in the day, this answer was very clear to us, where we thought that patients benefited from cytoreductive nephrectomy. This is taken from a combined experience between SWOG and EORTC, looking at the randomized benefit of patients who received a cytoreductive nephrectomy versus receiving just interferon, again, kind of an older agent, and may not be as applicable to things today. But however, looking at that combined SWOG and EORTC trial, it showed that a cytoreductive nephrectomy offered a survival advantage. So the common wisdom back at that time was that when the patient came in with metastatic renal cell carcinoma, the first thing that we had to do as urologists was to remove that primary tumor. However, when you look at this a little bit more, there was just very modest benefit, and the accrual period for these trials was actually quite long. And I think that the key to this, and I'm going to hammer this home for the rest of this talk, is that in these trials, nearly all patients received systemic therapy. Again, for those of us who were treating patients with cytoreductive nephrectomy who came in with metastatic disease, we knew that we were not doing the right thing for some of our patients. But again, we were following conventional wisdom, and we thought that we really had to get these primary tumors out. But it has been shown that patients who have metastatic disease, who have worse features in the actual primary tumor, or who have a poor ECOG performance status at the time of presentation, they actually do worse. And the reason for this, it's thought that by taking the tumor out in patients with very aggressive tumors or in patients who have a poor performance status, you will limit the receipt of systemic therapy in a majority of these patients, and that will actually affect their outcomes. So again, we know that we can perform cytoreductive nephrectomy in the wrong patient, and then certainly enough, this was proven with the advent of both the Carmina and the Surtime trials, which just came out. This is the Carmina trial, which looked at sunitinib alone or after cytoreductive nephrectomy in patients with metastatic renal cell carcinoma. Patients were randomized 1-to-1, and these are patients who presented with metastatic clear cell renal cell carcinoma. Looking at the Carmina trial, the results, it was a non-inferiority trial, and it showed, you can see that the curves completely overlap each other. Again, the key to this is that in the nephrectomy group, almost 20% of the patients never received systemic therapy. The systemic therapy in this situation was Sutent. However, in the Sutent group, some of those patients actually were able to go on to receive a nephrectomy. So again, the key to that is that these patients who were given Sutent up front, because they received the systemic therapy, that's where you saw the difference. This is the Surtime trial. The trial design is a little bit different from the Carmina trial. However, the results are very similar. For the Surtime trial, it was immediate cytoreductive nephrectomy, which was followed by Sutent, compared to Sutent alone, which was followed by cytoreductive nephrectomy in patients who failed to progress while they were on Sutent. And it's really this second arm that I think conventionally we are beginning to follow now, again, as a result of these two trials. And again, what this showed is that systemic progression before a planned cytoreductive nephrectomy in the deferred arm actually showed that some of these patients who actually progressed were placed on second-line systemic therapy. They did not go on to cytoreductive nephrectomy. So by giving a systemic therapy up front, especially to patients who may be poor surgical candidates, actually can not just prolong their lives, but may get them to a second-line systemic therapy, which can actually show some benefit. So again, So in reality, now we know that really for patients who present with metastatic renal cell carcinoma, we need to be very choosy about the patients who we perform cytoreductive nephrectomy on. Patients with good performance status who may have minimal metastatic disease burden, those are the ones who I think would benefit most from a cytoreductive nephrectomy. Otherwise, I think we should really look at giving upfront systemic therapy to these patients. Okay, so what do we know about cytoreductive nephrectomy in 2024? Again, I'm being a little bit redundant here. It does improve survival only if systemic therapy is delivered. Not all patients who undergo cytoreductive nephrectomy receive systemic therapy, and not all patients who undergo cytoreductive nephrectomy will require systemic therapy. And I do think that Carmina and Surtime did change things significantly, but I would like to point out that the systemic therapy used in these trials was actually Sutent. And as you can see, as I go on in my talk, there are going to be more up-to-date trials looking at cytoreductive nephrectomy in patients with more advanced and more modern systemic therapies. So, and looking at cytoreductive nephrectomy in the NCCN guidelines in 2024, again, it kind of mirrors what I was just saying. Patients should only be considered for cytoreductive nephrectomy if they have a good performance status and if they have minimal metastatic disease at presentation. So finally, the step 3, if we start, do we need to really start systemic therapy immediately? So in other words, can we delay systemic therapy in patients who actually present with metastatic disease? And this has also been looked at in a couple prospective trials. Again, active surveillance in patients who present with metastatic renal cell carcinoma. Here are the plots looking at these, and what it does show is that if we delay systemic therapy in a majority of these patients, we actually will see a survival benefit, especially for those patients who have favorable risk disease. And again, that shows the benefit of the actual classifications, which I mentioned earlier. So the answer is, again, maybe not. There is an opportunity or quality of life, so improve quality of life off treatment, and then again, only administer systemic therapy in these patients when they actually do progress. So we've all shown today, different timelines. I will take a term from my prior colleague or from my colleague in his prior talk. This looks like there was a barren wasteland of treatment really from the 70s into the early 2000s, when really only IL-2 and interferon were the only agents. And this is a historic document, almost looks like an NCCN guideline from back then. And really, to sum things up, really only interferon and IL-2 were what we had around the year 2000. And then we came into the targeted era, which was about 2005 to 2015. This was based on the discovery of the von Hippel-Lindau tumor suppressor gene. We understand that tumorigenesis is dependent on mutation to the VHL suppressor gene in more than 90% of patients who have clear cell renal cell carcinoma. And this is the mechanism outlined out here. The mutated VHL gene leads to an accumulation of hypoxia-inducible factor, or HIF, and this releases a bunch of transcription factors which lead to angiogenesis and finally tumorigenesis. As far as VEGF goes, which is one of those factors, as I mentioned, it's been shown that patients who are VEGF positive actually do worse than patients who are VEGF negative, which is one of the reasons why, when you extrapolate this out, patients with clear cell renal cell carcinoma have more of a chance of developing metastatic disease. Kind of a busy slide, but it was, again, the discovery of this gene and the downstream mechanisms that were related to tumorigenesis, which led to the burst of medications that were developed in order to block the various pathways that are listed all throughout here. And these are the targeted agents which kind of were part of the era that I'm talking about, that 2005 to 2015. Sutent was certainly the first that came out, and certainly the more popular of all of them, which is sunitinib. This was from, this is the trial that looked at sunitinib. It was compared to interferon in a 1-to-1 basis. Again, it very much outperformed patients. This was a primary treatment for patients who presented with metastatic renal cell carcinoma. Again, clear cell, and you can see in all the subgroups, Sutent actually outperformed interferon. However, that being said, one of the drawbacks of the targeted agents certainly is the tolerability. You saw a lot more grade 3 and grade 4 side effects from patients who received sunitinib, in this case, versus patients who received interferon. This is the dreaded hand-foot disease, which I'm sure feels just as awful as it looks. And this is one of the reasons why patients would come off the drug just because they just could not tolerate it. So you had that really poor tolerability of the targeted agents, which limited their use in these patients with metastatic renal cell carcinoma. Around the same time as Sutent or sunitinib came sorafenib, and these are the other agents that were looked at that time. One of the problems, however, is that in most of the trials that led to the approval of these agents, the targeted therapy was really randomized against, again, at that time, it was just interferon, because that was the only agent historically that we had that really showed any activity against metastatic renal cell carcinoma. And as we've determined, interferon was really a kind of an easy competitor just because it had such poor outcomes in and of itself. And I will say the sorafenib was actually randomized against a placebo. So more recently, pazopanib was looked at in the phase 3 COMPARES trial, but however, as opposed to the trials which I showed you just earlier, which looked at interferon as a comparator, pazopanib actually was compared against sunitinib in a 1-to-1 fashion in this trial. Again, patients with advanced or metastatic clear cell renal cell carcinoma were enrolled in this trial with the primary endpoint being progression-free survival. And this was also a non-inferiority trial. You can see progression-free survival, and the secondary endpoint was overall survival. The curves actually overlap each other. So you saw non-inferiority from a disease standpoint of pazopanib when compared to sunitinib, but I think that the more significant finding in this trial were the relative risk of adverse events. I already showed you how poorly tolerated sunitinib is, but in this trial, pazopanib, for all of these side effects, all these category of side effect, actually showed benefit or showed superiority as compared to sunitinib and better tolerability. And I know that at our institution, in the rare cases where targeted agents are being considered anymore, our medical oncologists are looking at pazopanib as that choice. So at 2015, these are the drugs that were approved by the FDA for metastatic renal cell carcinoma or advanced renal cell carcinoma. Again, all of these being targeted agents, all of them focusing on some aspect of the VEGF, HIF, and von Hippel-Lindau pathway. So again, we talked about the dark ages or the stone ages, that was interferon, IL-2. The modern ages, which I will call maybe the iron age, that was the targeted era. And now we have entered the golden age of treatment of metastatic renal cell carcinoma. Again, you can see all of the agents that have come out at that point, which I will go through at from this point on. The first agent that I'm going to talk about, actually, which is considered in the golden age, is cabozantinib, which is actually a targeted agent. However, it's a more advanced targeted agent because it has multiple targets, going back to that slide that we saw earlier, where all the different mechanisms in the von Hippel-Lindau cascade of targets. You can see that cabozantinib hits multiple targets, including VEGF, MET, as well as AXL. So CABOSUN was the trial looking at first-line treatment of metastatic renal cell carcinoma. In this case, in patients with poor or intermediate risk patients. Again, the majority of patients who present with metastatic renal cell carcinoma are poor or intermediate risk. So in this trial, the patients who presented with this disease were actually randomized 1-to-1, cabozantinib versus sunitinib. And here were the results. The progression-free survival was improved with cabozantinib 8.2 versus 5.6 months. And the rates of grade 3 and grade 4 adverse events, again, these are both targeted agents, but it was no different between the cabozantinib and the sunitinib. So it had better response, but was just as well tolerated. And as a result of this, cabozantinib at that time was approved for first-line metastatic clear cell renal cell and non-clear cell renal cell carcinoma. However, I do think that the class of medications that made the biggest splash with metastatic renal cell carcinoma were the immune checkpoint inhibitors. This was a trial that looked at kind of the response rate of pretreated metastatic renal cell carcinoma with nivolumab monotherapy versus, in this case, everolimus, which was a targeted agent. Again, these patients were pretreated, and you can see from the beginning the curves certainly were disparate. And you saw a benefit of nivolumab over everolimus in this case with a hazard ratio of 0.73. I do think that another significant point here is that the grade 3 or 4 adverse events in this trial were much less for the IO therapies, for the immuno-oncologic or the checkpoint inhibitor, versus against that targeted therapy adverse event. So not only did it outperform it from a cancer standpoint, but it was much better tolerated. So we saw that there was likely going to be activity against renal cell carcinoma in patients who were treated with the immuno-oncologic agents. So it was this trial that gave us a lot of promise. So nivolumab was combined with ipilimumab in the CheckMate 214 trial. Nivolumab is an anti-PD-1, ipilimumab is an anti-CTLA-4. So again, they're both checkpoint inhibitors, but they're targeting different molecules. Going back to that slide that Ed showed, there are a lot of targets out there, both ones where you step on the gas and ones where you take your foot off the brake. These are both taking foot off the brake. In this specific trial, patients were randomized 1-to-1 for metastatic clear cell renal cell carcinoma. Again, this was for patients who were untreated, so this was first-line therapy. And the results of this were actually quite impressive for both progression-free as well as progression-free as well as overall survival, with the hazard ratio being very impressive. The objective response rate was 42% versus 27% in the Sutent arm, and actually the unicorn of renal cell carcinoma, there was actually a complete response rate that was 9% versus just 1% in the Sutent arm. So now you were seeing patients who were having complete responses who had presented with metastatic renal cell carcinoma. Again, this was a combination regimen, but they were both immuno-oncologic agents. Again, this was randomized against Sutent. And you look at the AEs, and even though it was a combination regimen, just 46% grade 3 and 4 AEs versus 63% in the Sutent arm, which was consistent with what we've seen in the past. So again, much better tolerated. And it was a result of this trial that ipi/nivo was approved for first-line treatment, again, in the intermediate to poor risk metastatic renal cell carcinoma. So when they performed a subgroup analysis of this, looking at the risk groups, they saw that really the benefit in this regimen was really only seen in the poor to intermediate risk metastatic renal cell carcinoma. However, when you looked at the favorable group, Sutent actually held some superiority there, and when you saw the NCCN guidelines as a result of this trial, the NCCN guidelines actually split patients up based on their IMDC classification, and patients with poor risk or intermediate risk, the ipi/nivo was actually considered a preferred regimen. However, Sutent still stayed in the NCCN guidelines at that time for patients who had favorable risk disease. So now we know that we have targeted agents which work against metastatic renal cell carcinoma, and now we know that we have immuno-oncologic agents which work against metastatic renal cell carcinoma. So now we've decided that we are going to combine these regimens into a combination therapy different from the Ipi/Nivo, which are both immuno-oncologic agents. And now we're in a new era where we're looking at combination therapy, targeted therapy, and immune therapy. Pembrolizumab and axitinib was one of the first trials or one of the first regimens that was actually looked at in the Keynote 426 trial. Patients were randomized, in this case versus Sutent, with the Pembro-Axi regimen versus Sutent, with their primary endpoint being overall survival and progression-free survival. And you can see, again, the curves separate very, very early, and this is progression-free, this is overall survival, so you hit both of the endpoints with the overall risk rate being 60% in the Pembro-Axi group and 35% in the Sutent group. And the key of this study is that the benefit of Axi-Pembro was actually observed across all IMDC risk groups, as opposed to the Ipi/Nivo, which I just showed, which was just for poor and intermediate and poor risk groups. The benefit here for this combination regimen was across all all groups. The adverse events, again, now you have a targeted agent in both arms. You have the Sutent and the axitinib. You have the Sutent in the one arm and the axitinib in the combination arm. So now you're seeing the adverse events actually being very consistent with each other. However, it was because really of the response rate that the FDA approved Pembro-Axi for first-line advanced clear cell renal cell carcinoma. This was back in 2019. Another regimen looking at, again, that more sophisticated, certainly a little bit later generation targeted agent cabozantinib. In this situation, combined with nivolumab, randomized against sunitinib, again for patients who presented with metastatic renal cell carcinoma. First-line treatment, this was the Checkmate 9ER phase 3 trial with the primary endpoint being progression-free survival and overall survival as a secondary endpoint. And again, just like with the prior trial, this was not unexpected. You saw the curves separate significantly in patients who had the combination therapy versus Sutent. So based on this trial, in 2021, the FDA did approve the combination of nivolumab and cabozantinib as a first-line treatment, again, for patients who presented with metastatic renal cell carcinoma. And just like the prior trial, this was recognized against all IMDC risk groups. More recently, another combination regimen, in this case lenvatinib and Pembro versus everolimus for advanced renal cell carcinoma, another phase 3 trial. This was randomized actually 1:1:1. In this case, this was a lenvatinib, which was also a newer generation targeted agent. It's a multi-kinase inhibitor, plus Pembro versus lenvatinib, plus everolimus. And then finally, they have that comparator group, the Sutent, at the very bottom, again, looking at progression-free survival as a primary endpoint and secondary endpoint, overall survival. And in this trial, you saw certainly in the lenvatinib Pembro arm, you saw really the biggest improvement in survival actually here, which led to the approval of this. So based on this trial, again, the FDA approved the combination of lenvatinib and Pembro as first-line treatment, again, for patients who presented with metastatic renal cell carcinoma. So going into the NCCN guidelines to 2024, again, different from what I mentioned to you earlier, they are separating the patients into a favorable versus poor and intermediate IMDC risk groups. And for all the preferred regimens, in both, really, it's going to be a combination targeted therapy plus immuno-oncologic. However, I do believe that Ipi/Nivo is also considered a preferred regimen, and cabozantinib still maintains a role in these patients with poor intermediate risk first-line treatment. Again, that kind of goes back to that compares trial, which I showed you earlier. As far as subsequent therapy, so again, second line and beyond, if patients have been treated, you have to stratify it with patients, whether they've been already exposed to IO therapy or whether they've not been exposed to IO therapy. Obviously, if they've had prior IO therapy, the options are a little bit less. Now you're looking more at the targeted agents, whereas if they have not had IO therapy, then a lot of these combination regimens are actually in that algorithm. But still, again, I've been talking mostly about clear cell renal cell carcinoma. There still is a need to consider patients with a non-clear cell histology, which in my practice do represent a fair amount of patients with metastatic disease. When you look at the preferred regimens, again, that cabozantinib still holds true. However, beyond that, we're looking at clinical trials. Some of the combination therapies that we mentioned actually have found a role here, but again, the results are pretty poor. So really, this is the one of the needs right now is the regimen to treat these patients who present with non-clear cell histology and metastatic disease. As I mentioned earlier, there's still, even though there's all this excitement about all the regimens that have now been introduced, really there's a lack of head-to-head comparison in between them. Really, the only comparator that most of these trials looked at were targeted agents, with Sutent being the lead comparator in most of these trials. Okay, I'm going to break off into localized disease real quick. I know we were talking about metastatic disease, but there are some exciting there's an exciting evolution with treatment of localized disease with systemic therapy, and that really is with the in the patients who have locally advanced tumors or metastatic disease that with complete metastasectomies, who you ask yourself, what can I give them in the adjuvant setting? There was obviously for the longest time nothing, and now there's a lot of excitement about what can be available. And I'll get into that in a second. So this is kind of the trials that we were involved in, some of them that looked at the, again, in the targeted agent era, looked at the benefit of adjuvant therapy in all of them. Unfortunately, all of these trials, except for the S-TRAC trial, were negative trials. So again, looking at various targeted agents, Sutent, everolimus, but unfortunately, none of them came back to be positive trials, again, except for the S-TRAC trial. The problem with the S-TRAC trial is that it showed benefit in progression-free survival, but not overall survival. So we didn't really know what to do with this. Again, because the S-TRAC looked at Sutent in the adjuvant setting, again, because of the poor tolerability of Sutent, as we talked about, I know that our medical oncologists were hesitant to give it in the adjuvant setting, so this didn't really change anything for us, even though the FDA did approve it, right? So, however, again, August 2021, this the Keynote 564 trial was reported out looking at adjuvant pembrolizumab in this setting. And again, the eligibility criteria are listed here. Again, patients with either locally advanced disease, so T3 or higher, lymph node positive, again, patients who had minimal metastatic disease, who had complete metastasectomy, so they were disease-free at that time, or patients who had large tumors, pathologic T2, so 7 centimeters or greater, and a nuclear grade 4. So these were the eligibility criteria where patients entered the trial. These patients were randomized 1-to-1, and pembrolizumab was compared to placebo in this situation. The primary endpoint was disease-free survival, with the overall survival being the secondary endpoint. And this was very exciting to us when this was reported out. It showed that it met both its primary progression-free survival as well as the overall survival endpoints. And the risk of disease recurrence or death was 32% less with adjuvant pembro than with placebo. And the median overall survival was not actually reached in either group. So based on this, the FDA did approve pembrolizumab as adjuvant therapy in patients who are at risk for recurrence. So again, those patients with locally advanced disease, T3 or above, those patients with large tumors, T2 or above, so but that were localized, but high grade, and patients who had complete metastasectomy, that these pembrolizumab has found its way into the guidelines in the adjuvant setting. And actually, if you look down here, Sutent is also considered here, although is not the preferred regimen. And unfortunately, for non-clear cell histology, these are for clear cell histology. For non-clear cell histology, we do not have anything available, so they're recommending either surveillance or clinical trial in that situation. Okay, so that was a whirlwind. We do have cases that we can present. Yeah, we're going to do great. So, but before we get into that point, we'll go ahead and take questions from the audience. I would like to say that we're being live streamed, so if you do have a question, please use the microphone. All right. No questions equals happy audience. So let's move ahead. We have 6 minutes left. I have some cases that I brought up. We actually presented these cases when we first had this, when we first gave this talk 8 years ago, and it's interesting going through these cases and updating them because you see all the developments that have occurred in the last 8 years with prostate, bladder, and renal cell carcinoma. So our first patient, and I'm just going to go ahead and cold call on my panel here to see how they would treat these patients. This is a patient who presented in 2010 with a PSA of 1.6, who had a nodule. He did undergo a biopsy. It showed what now is considered grade group 4 disease with a primary Gleason 5, maximum core involvement 100%. Staging options. At that time, this is what we were considering. I did have to change this a little bit. How would you stage this patient, Mary? So grade group 4 disease, probably considered high risk in that situation with a primary grade 5, high volume.
Yeah, I mean, we could, for high risk, we could do PSMA PET.
Yeah,
Yeah.
so,
Yeah,
Yeah.
and that's something we've been moderately successful getting insurance approval for initial staging of high-risk disease, and there seem to be softening up on that.
They are, yeah.
oh, I didn't realize that they included this in our in our audience response. So I'll let you guys go ahead and pull out your phones and answer this. Sorry about that.
Surprise.
We'll keep going. So of course, this was 2010. This was prior PETs. The patient had a CT urogram, probably presented with hematuria. That showed no Mets. Bone scan at that time also showed no Mets. So the patient underwent a radical prostatectomy or robotic prostatectomy, upgraded to a grade group 5 pathologic T3 disease. And how would you treat that patient now if they showed up with that pathology, Mary?
Typically in our practice, we do talk to patients about adjuvant radiation therapy, but for the most part, we put people on close surveillance and follow the PSA.
Yeah, and we also utilize genomics in this space. This is a patient we probably would order a Decipher, and if they were high-risk Decipher, then we have a little stronger conversation, shared decision-making about early adjuvant radiotherapy or delayed salvage. And as Mary said, definitely keep them on close surveillance. Wouldn't space out their PSAs more than 3 to 4 months.
So there's the question. We're not going to go through it. All right, so the patient has a biochemical recurrence. Of course, this was a different era. Patient had bicalutamide started with Lupron and had radiation treatment, so post-prostatectomy radiation in the salvage setting. That patient did have a biochemical response, may have been due to the Lupron at this point. However, the PSA took a rapid increase after that. So, and we did repeat staging studies. What staging options do we have now currently at this time, I guess is going to be my next question.
can get the PSMA PET approved in
Right.
that context. If not, then conventional CT and bone scan.
Yeah, certainly I think that the PSMA PET scan has just changed everything. I mean, we had so many options, Axumin, the sodium fluoride PET, which we performed a lot of at one point. We don't really see that much anymore. The more conventional bone scan and CT scan, CT of the chest probably has no role here, but anymore we're getting a PSMA PET on these patients with a biochemical recurrence after definitive local therapy. So this patient goes on to develop castrate-resistant disease. 1 minute. So, we'll go through it. And this is the, these are the interventions here. We go ahead and get staging studies. Apalutamide was started on this patient in May of 17. Obviously, continue the Lupron on this patient. However, the PSA continues to go up. We do get a bone scan on this patient, which shows osseous metastasis. So now this patient has metastatic castrate-resistant prostate cancer. Here are our treatment options. What would you do in this patient, Mary?
Oh gosh, we could do single agent docetaxel in this context. Since he's metastatic castrate resistant with bone mets, he could also get supportive care with denosumab to help prevent skeletal related events.
Radium-223, maybe? Sounds like it was bone-only disease.
Maybe, yeah.
Yeah. So,
And if any pain, he could get, we could consider doing palliative radiation.
yeah, if
for
it's a
pain
if it's a
management.
solitary met.
Yep.
Okay.
And CYP is still on the treatment algorithm for asymptomatic or minimally symptomatic. I'm not sure how much it's offered anymore. I think maybe more in the community than in the academic centers.
Great.
We'll do a 10, yeah.
All right. So, well, we are out of time. Thank you very much, everybody. Again, thank you to the AUA. And hopefully we will see you guys next year. All right. Again, thank you to Mary.
Thank you.
So, nice job, Mary.